Welcome to this week's episode of Pain Science Education. On this week's episode, we're going to be talking about deprescribing medication or tapering different types of medication. Our guest this week is Dr. Aimee Perron. She is a licensed physical therapist, as well as a neurologic certified physical therapist who is working at the forefront of deprescribing medications and medication management for people with pain and other neurologic conditions. Now, this can be a really trigger and hot button topic for a lot of people. And we're not suggesting on this episode that medication does not have a place in chronic pain or other chronic conditions, but we are suggesting when medication or medication management is not tracked properly, that it could be potentially harmful for people living with pain and other conditions. So we talk about how to use medications appropriately on this episode, of course, combining that with strategies like physical therapy to help people recover and manage pain, as well as other chronic conditions. So super important episode. I thank you all for joining us this week, and let's get started. Hey there, Aimee. Thanks for joining me this week.
Hi, Joe. Thanks for having me. It's very nice to meet you.
Yes, I'm excited to speak with you today about this role of deprescribing as a physical therapist. I'm really excited because I'm not sure if you're aware, but years ago, I did one interview with a British physical therapist. You're probably aware that in the UK, they can obtain a license where they can prescribe and deprescribe. I would love to see that in the United States, and maybe we're moving in that direction. But I'm excited to, I came across your work at last year's CSM, and I said, I have to get Aimee on the podcast and learn about her work in the area of polypharmacy and deprescribing. I think a good place to start is just tell us a little bit about your background in physical therapy and how you became interested in the role of deprescribing as a physical therapist.
Sure. Thank you. Well, I've been practicing for about 25 years, and a huge part of my practice has been in post-acute, so inpatient facilities, working with the older adult as well as those with neurological conditions. And I kind of have like two examples as to why I've got into this. One is actually not even as a physical therapist, but I'll start with my physical therapist. Um, I was working at a facility with folks who had traumatic brain injury, and the short version is that I was working with them, and the medications they were being put on to help them with their recovery from their brain injury, or maybe some of their mood disorders from as a side effect or secondary consequence of the brain injury, was making them more spastic or making them more fatigued. All of the things that were interfering with my ability to do their physical therapy. And so because of that, I had a conversation with the psychologist, and fast forward a little bit, became involved in the medication review rounds, and we really started to see how coming together as an interprofessional team made a difference. It was in a situation where I was very fortunate, where they tracked because these individuals needed to be checked on frequently. They were able to track their moods, so whenever medications were changed, we were able to look at the data and say, oh, this is working, or oh, it's not working, and then really work together. I know we don't always have those circumstances, but that was kind of the beginning of the journey. And then kind of being very involved with my grandparents and asking questions about medications they were being prescribed, and seeing how actually how much medications get layered on and layered on and layered on, and asking some questions about that, and saying, hey, well, why don't you just take them off of this medicine instead of putting them on this, right? Which I've since learned is like there's a lot of science and data around that, called I think it's called the pharmacy cascade, or the polypharmacy cascade. I didn't know that at the time. But so it was kind of those combination of those two things that really got me more interested in being involved, realizing the importance of this in our practice.
I love the story. And it just, I think about, I'm sure this is resonating right now with a lot of physical therapists and other health providers who are seeing patients. And, that cascade to me is a really, interesting term, because we see this, right? Patients come in with a couple medications, and oftentimes we're seeing patients for a long time. So we're getting to know them, and their medication history is evolving or cascading, as you were saying. Now, with that cascade, oftentimes what happens is there's multiple medications that are being prescribed. Um,
Mhm.
Sometimes from one provider, sometimes from multiple providers. Tell us what polypharmacy is in your own words. Maybe make it simple for those who are not healthcare providers, and why that should be a concern for both healthcare providers and for the general public.
Sure. I love the question. I love starting with definitions, but more importantly, because I've been asked this question a few times, right? And in my, interest in this, I've looked at it. And so polypharmacy oftentimes, like foundationally, is described as more than five medications, and people focus on that. But when you really dive into the literature, what's more and more important is it could be a couple of medications, but if they're not appropriate or they're causing harm than benefit, that also falls into the definition of polypharmacy. And certainly we see more concerns when you have these older adults with chronic conditions and you have this polypharmacy cascade where you have multiple health providers layering on medications. That is certainly a part of it. But I think the big question, to simplify it, like you asked, is are they on a medication that's causing a harm and not giving a benefit, or the benefit isn't outweighing that harm?
Can you give us an idea of what those harms are? Because I think people are, definitely people who listen to this podcast are very aware of the potential harm of long-term or high-dose opioid use for people with pain. But I realize, and you and I spoke a little bit before we hit record here today, you're working with whole classes of medications, not just opioids. You're working with a whole realm of medications that are probably going to be surprising to a lot of physical therapists. So I guess tell us a little bit about that as well.
Yeah, sure. I mean, one that I like to start with is acetaminophen, right? Or
Tylenol,
and
basically.
yeah, Tylenol,
Mhm.
right? Or the non-steroidal anti-inflammatories. Over time, or if it's easy to get, right? So it can be prescribed and it can be over the counter. Obviously, when it's prescribed, it's higher dosage. But I think it's because it has that over the counter ability. Then there's these myths that that it can't be unsafe. And we can see chemical toxicity from too much of that in the body. We can see GI bleeds from that. We're even seeing some data coming out that it's changing cardiovascular responses. And so I think that's like the number one that often kind of comes to my mind, right? But the other medication that comes to my mind that I see so much that I'm actually quite surprised that it gets prescribed as easily as it does is the benzodiazepines. So, we talk a lot about substance use disorder and addiction when we were talking about opioids in relationship to pain. But many times those individuals are also on the benzodiazepines because they have anxiety because of the pain or for whatever reason, or they're using it for sleep. And, not to get too down the weeds of the pharmacology of it, right? But we all had to learn that in school, the half long it takes to from the longer that is, the higher it is. And the diazepines are pretty bad. And I've seen some cases where individuals have a tough time coming off of that, right? So there's that side of it. But then as a physical therapist, we see dizziness, we see postural hypertension, and then obviously falls are a big concern. And those are like the top ones that I'm thinking of that's just coming to to my head right now. But yeah, I think you raise a good point, Joe, is that there are a lot of medications that we should be looking at and being aware of because it can impact our patient's ability to function and then perform and get and meet their goals and the highest outcomes that we're trying to achieve as therapists.
Hmm. So we should be aware, of course, opioids we're aware of, the benzodiazepines, the ones that are over the counter, which can cause toxicity and harm too,
Mhm,
like
mhm.
basic Tylenol, Advil, all the other non-steroidal anti-inflammatory drugs. How about the gabapentins? because oftentimes they're prescribed um, for pain or for anxiety, and they're not quite a class of benzodiazepine, but oftentimes they're used because they're seen as having less side effects or causing less dependency, shall we say.
Uh, yeah, it's a great question. And I've never been asked that question. So thank you for the question. Some of my experience with that is the fatigue that I see with the patients from gabapentins. And I mean, like, and sometimes they're taking that in higher dosages and they're very tired, like falling asleep, during the session, sort of thing. And then having some of those other consequences of maybe some postural hypertension. I don't actually know. I've seen that. And I'm thinking of cases. I can't say for sure that's exactly what it's from, but I know the fatigue is definitely something that I've seen. Have you had experience with that as well?
I have, I think, well, once the kind of opioid um, awareness came in, people were looking for other medication, physicians, because it's primarily what they do. And I admire, I definitely admire a skilled prescriber, shall we say. And then there are prescribers, and I think this is where, all of our work starts to come in as conservative professionals, then as kind of a, I think a safety gap in some way, where I've seen people placed on things that are high dose, or they've been placed on medications like the gabapentins where they haven't been monitored. And I think, and I'd love to get your feedback on this. Oftentimes, someone goes to their primary care doctor, or they go to their pain management doctor, or they go to their psychiatrist, they're prescribed a medication. Um, the physician, because they're busy and we don't really have a system for this, don't call the patient and say, how are you doing? Or let's follow up. Do we have a role in that area to, um, you know, both advocate, I would say, for the physician and for the patient in a safe approach to medication management?
Yeah, and this is exactly where I think we do belong in the space. And I like to say, like, I think there are a lot of physical therapists that at least gather a medication review. They'll say, what are you on? And there's probably certain classes of medications that therapists will focus on. Like, I'm treating you post-op, and when do you get your pain? I'm treating you and you have Parkinson's disease. When do you get your medication? Like, I think there's like certain things that we see that are typical in practice. What I encourage physical therapists to do, and would like to see more of it, and I'm hoping and would love to talk to more people that are doing this, is spending the time asking about, like, what are you on? Why are you on it? Are you having any side effects? What's fascinating about the conversation when you do start doing this is the lack of knowledge that individuals have about their own medication regime, and then to tie and connect that this medication is matching that side effect. They don't even know why they're on something. And I agree with you. I don't think that the structure in the organization, our organizational structure in the healthcare system right now is set up for those good quality conversations. And what we are afforded as physical therapists is more time with our patients. And I know that sometimes when I get the question, Joe, actually about this is like, well, I have so much to do with them. How am I going to do this too? I always challenge individuals back saying, you're going to be more successful. Like, it's going to create a roadblock if you don't address it. Either address it now or you're going to have to address it later, right? That old saying.
Yeah.
And so really, I think there is a huge role in us being part of that care team. And I think that, not to go on too much of a tangent, but we are starting to see kind of the payers appreciate us a little bit more in this space. We've seen that we're now being paid for remote therapeutic monitoring. This year, the caregiver codes are coming out. So there are things, I know that's kind of a sidebar, right? But there are things that are happening in our physical therapy world where the payers are starting to see the huge role that we play. And I think as professions, we're advocating. So to go back to an earlier statement, you said having people being able to prescribe. We can see that already in um, folks, the physical therapists that work in the military. They
Hmm.
can do a little bit more. And I think that the more that we show that we have the skill, we have the knowledge, we have the case outcomes, we'll be able to do more of that. There'll be less barriers for us. And I think that's sometimes what stops individuals is the organizational barriers. And then that's what puts the patient in this predicament,
Yeah.
for lack of better words, in the first place.
Yeah. And I appreciate the lens on the patient because obviously, we're all here to improve people's health and well-being. And it can be very confusing for the public um, because of media campaigns. It looks like medication is the only option. If I was placed on this, why should I now be taken off it? And I think there's a lot of fear around that too. I'm not sure if you have experienced that with patients where they're very fearful of coming off the medication, so to speak.
Yeah, when you look at the research, Joe, actually, it's one of the top reasons as a listed barrier as to the deprescribing world, right? That if we're going to work in deprescribing and helping reduce dosing, I mean, it's not deprescribing isn't just coming off a medication. Sometimes it's reducing dosing.
Mhm.
And it's layered because again, to go back to what I was saying before, if the patient doesn't understand what they're on for something on a medication for, you have to start there because there's certainly going to be fear and and we're not the ones prescribing it, so then they are in this kind of conundrum where they're conflicted because I have one healthcare professional telling me one thing, another healthcare professional telling me something else. They probably have a more intimate patient to therapist relationship than they do with their physician, maybe not, but they also kind of understand the hierarchy of culture that still exists. The physician kind of has that say, and all of that leads to confusion and fear for certain. Um, what we have to come to the table is providing an alternative to them,
Mhm.
to minimize that fear. And there's some research out there too that looks at what you should do, right? And you should introduce a choice. And part of that is those non-pharmacological approaches that we can offer them, and kind of talk to them about the risks and benefits of if they do this with us in physical therapy, what are the risks and benefits? We do that in practice anyway, right? That should be part of our patient education. And all of those things have been shown to minimize that fear, but it is a real thing.
So I'm curious because I know a lot of therapists are probably wondering what this actually looks like in practice, so to speak. Um, we still have this kind of like traditional view of physical therapy where you come in and people are getting stronger and more flexible and their function is improving, and all that is of course important. Still in a very impairment-based model.
Hmm.
Um, we have these other like psychologically informed care and health promotion models that are very, I think, important and I would say rapidly rising to the top at this point. And with those models, there's a lot more kind of counseling and coaching that's happening. And the therapists I know who are in those types of roles are actually very comfortable sitting down with someone for 30 minutes and saying, I noticed that you've been complaining about dizziness. And, when I evaluated you, your vestibular system seemed fine. But when I look at your chart, I think this might be coming from an adverse side effect to X, Y, and Z medication. Are you comfortable sitting down with someone and having that conversation for 30 minutes? And should we be doing that as a primary intervention at some point when people are having adverse reactions?
I am comfortable, and I absolutely agree with you. I'm thinking of kind of these comments and statements that I've had with different individuals and kind of defining us as, hands-on therapists. And I have tons of examples where I can challenge individuals back,
These are the naysayers, so to speak,
then
right?
yeah,
So are the
I
naysayers PTs or are they other people as well?
both,
Yeah,
both.
yeah.
And I've done a lot of telehealth in the COVID years and even before, and you know, was challenged by colleagues and others, but was pleasantly surprised and inspired by what patients can do when they are on their own.
Mhm.
They're coming to the table, they know they have to do something on their own. And it's taught me a little bit more about what I can do in this space, about being okay without not having to touch somebody. I can do tons of tests and measures. I could do a 6-minute walk and a gait speed and a Berg balance test and never touch the patient.
Mhm.
Watching them, listening, observing, gathering information. So how's that any different than a conversation as
Sure.
part of the assessment? And I think it's really an important piece. I don't think as therapists, we also spend enough time talking to patients about their goals. That's foundational practice. I've been practicing for a long time. We learned about patient goals. How many times have I asked patients, and I've been also in an administration type of role, and I'll ask patients, what's your goals in therapy? And they don't even, I have goals, is the response that I get back. And I've been using a tool called the patient specific functional scale a lot to gather goals and have them score their goals on that. It takes a little bit of time sometimes to just go through that and explain it to them and gather their goals. But it's so insightful in my treatment plan. And so anytime that you can have that conversation with them to gather more information, it's assessment.
Right. Yeah. I mean, I've been preaching this, I think, from the top of the Empire State Building here in New York City, that coaching and counseling is an essential part of what we do as physical therapists. We have always done it. I think probably you and I, Aimee, have been practicing probably, more than 20-25 years, so to speak. And we started practicing before all this terminology of coaching and counseling and psychology informed care. And I'm like, I've been doing this since day one, since 1997. Now we have a name for it, and
Mhm.
it kind of, makes people sometimes a little bit nervous. But once you start doing this, you realize that, wow, I can sometimes have a bigger impact on people if I start to educate them, work on goals, work on all the things that, that you're talking about here, not necessarily place my hands on them. I think it's higher value care. I mean, I would imagine you would probably think, or you'd like to let our listeners know that if you want someone's function to improve, but they're on a medication that's causing them to be dizzy, that conversation has to happen first before you can move
Mhm.
on with some of the essential musculoskeletal care or neuro musculoskeletal care, so to speak.
Yeah, absolutely. I mean, I think you're not going to get them to where they need to be. And they're the downstream consequences of that can be so large too, right? Now you have a patient that says, I went to physical therapy, it didn't help me, right?
Right. That's right.
They have friends that they're going to talk to and say, that doesn't work.
Yeah.
They may even lose their own kind of self-reflection on what maybe they have now a new outlook on. Oh, I went to physical therapy. That was kind of my last hope. And now what? Which leads them to other problems, right? You know, we don't always think about those things.
Yeah. I think we
So
saw that a lot with the, opioid epidemic, where we realized, okay, this drug, an opioid, is having an adverse impact on neuroplasticity
mhm.
because it's causing pain to get worse, right? So I'm coming in with all my tools and skills that I'm trying to move neuroplasticity or plasticity in a positive direction, but unfortunately, this dose of medication is preventing that. Versus someone looking at a medication where like it's going to like, fix something, so to speak.
Yeah. Um, I think kind of the general public doesn't always understand that, although they may have a better understanding with all the movies on big pharma and kind of
Yep. Yeah.
what you just explained, right? Like it's not fixing it. You're going to just need more, want more kind of thing because it's not getting to the problem. Um, I think this is also opens up a space for us as physical therapists to do more education to our patients that we can actually potentially treat the root cause if we do a root cause analysis and figure out what's going on, right?
Mhm.
And actually match our patient needs to our patient care. Um, and that is not always the case. Like you said, some medications can get to the actual problem and create a treatment that will minimize the progression of the disease or the problem or the cellular problems that are going on. But you're right, other medications are just treating the symptoms. and not getting to the root cause. And I think that's what opens the space for us as physical therapists, because we know we can do more.
Speaking of opening this space, I know there are providers listening to this who are probably getting charged up by this because they're seeing this happen, whether they're working in a nursing home, because polypharmacy is oftentimes
Mm-hmm.
seen in our older population, right? And maybe we should touch on that because I think, whenever we start talking about opioids, people tend to think of like one single drug, maybe a younger person who's working and who has back pain. But this is essential for older people, right?
Absolutely. Um, and while you're talking, and I'm thinking of this one case of an individual who was ambulatory, living in a skilled nursing facility, stopped walking, became bedbound. And it was because of the combination cocktail of adding one more medication to an already really long list of medications and encouraging the therapist to have the conversation. And when the team came together and said, why is this individual on all these things? It really elevated that this polypharmacy cascade was occurring. And it was just put them on this to treat this, and then treat this and treat this and treat this. And the patient got lost in that and became like pretty much a bedbound, not really alert patient.
Yeah.
And it really, so the next step was to get the patient off the medications. And that's where it really comes in as a team, because where we are also, again, spending time with the patient, how are they doing as these medications are being tapered off? Some need to be tapered in a very specific prescriptive way.
Mm-hmm.
And we can provide information along the way that can help drive more success in that space. And that individual actually came off of 4 meds and became ambulatory again.
It's amazing.
And that's the stuff we love as
Yeah.
therapists,
Yeah.
right? We want to see our patients succeed always. And I think it's a little bit easier in this space when the team is at rounds in the morning and we can talk, and it's a little bit harder in the private practice space where you have to pick up the phone and make a call. Although I think technology allows us to be able to communicate a little bit better in that space, and then inspiring and encouraging the patient to have the knowledge to bring to their physician as well. But we certainly do see that much more, I think, in facility based, because maybe sometimes the patients can't articulate or advocate for what the needs are, and so the team is doing the best that they can, but they're kind of guessing at it. And like you had said earlier, we tend to be a culture of fix it with meds. They got a problem, give a med. And again, where we need to advocate and be change agents for physical therapists is educate continuously, still, even at this state and where we are as a doctoring profession, explaining to the other healthcare professionals what we can provide. Because I think there's a misunderstanding as to what we can do as physical therapists.
Mm-hmm.
And so if someone, comes with this new problem, maybe they're not sleeping well because they're in pain. And it comes down to positioning. And we have a lot of skill in that space. It would be great for the physician, instead of to giving them a pain medication and or on top of it a sleep aid, why don't we have physical therapy go in? And which may mean changing our time of day that we see the patient
Mm-hmm.
in a different setting, not in the gym, right? And providing treatment that addresses that problem. But that's not always usually the case.
Yeah.
That's not usually the order of events.
So what would you recommend to a physical therapist who wants to start in this area? I mean, I know there's um, places to start in your own practice with your own practice habits, and there's probably places to start with interprofessional collaboration. And I would imagine also educating yourself on um, some of the medications that we've already spoke about today in some way. I think in some way, this is again, I really appreciate you being here. This podcast is a nice intro for people to say,
Sure.
okay, here's some things I have to start to learn more about. But what would you say those key areas are?
Sure. I mean, I think it's really doing a good self-assessment as to where you are. For me, I graduated before I was a doctoring profession, and in a way, I feel like that created a nice, I was a more of an adult learner, ready to learn in a different way when I went back to get my doctorate, and part of that was taking pharmacology. And so I think I probably took more away in my late 20s, early 30s than I would have when I was younger, and really was able to put that into practice. So I would say first start with education. Like, where do you sit in this space with knowledge about medications, and not be intimidated by it? There are a lot of great websites and tools and apps now that are so helpful to make it easy. And kind of they put it in layman's terms. And when I say be aware of the medications, I'm talking about not just the name, but the classes, kind of the key side effects, but the side effects that jump out to us that we know are going to impact our ability to work with patients. And then comfort level, and being okay with being vulnerable on the interprofessional team that you're on, whatever space that's in, to talk to, to be able to say where you are in that space. Because I think sometimes physical therapists have shared with me that they've brought it up and they haven't been received well to be having a conversation around medication. So, and someone said to me not too long ago, like, it's easier to have difficult conversations with your partners and your colleagues if you have a relationship. So it starts with making sure you have a relationship with those people. And maybe that means the pharmacist, maybe it's having a conversation with them. Then what tools do you have? Again, and going back to the question around inpatient care, be comfortable with the EMR. I use that all the time. I actually have used it in the sense where I'll just sort by patients who are on opioids. Like, the big data tools that we have now to be able to sort that way. So if you're in a organization based, not just private, I mean, maybe even private practice, you're able to pull out some data depending on the system that you're using. But in home health, you're probably able to do that. And then patients in skilled nursing or assisted living or independent living, then they may not be on services, but they may come up as people that you can screen and do specific screening events, and kind of be more proactive in nature. So that's another way. But I would say those are kind of the big things. We are committed to lifelong learning, which means it's a journey. So where you are in the journey of understanding medications, maybe you classify it into a specific space to start, so it's not overwhelming. Maybe it's around pain medications, right? And maybe you bring a certain skill. I'm thinking a lot of the listeners here bring a skill on treating pain. So let's look at some of those specific classes of medications and understanding. But we're not the ones that are going to take the patients off the medication. So it has to also include developing skill sets and having the conversations with patients, and then developing skill sets to have conversations with interprofessional partners.
Yeah. I think there's a lot of power in the position you're talking about, because for so long we've kind of looked at ourselves as allied health professionals, so to speak, which we're not, and I want to make that clear. But the fact that we can sit in the position where we can advocate for the patient and also in some way advocate for the prescribers, so to make sure that they're aware that their patient's not doing well, because there's liability there as well for them, right?
Sure.
It really puts us in a nice kind of, what I kind of imagine as like a keystone position, where if we weren't there, if we weren't a part of that episode, then there may not be communication between the patient and the doctor, maybe until things get too severe. So I think that's really exciting for us to kind of think about.
Yeah, no, I love that example. It's a really good point.
Yeah. Aimee, it's been great speaking with you today. I love the work that you're doing. And I know other people are going to be interested in hearing about this and sharing it on social media. If they want to reach out to you, they want to follow you and your work or learn more, how can they find you?
Sure. Well, I am faculty at Northeastern University in Boston, so that's one way to find me. But I also have a pretty active, I think, sort of active LinkedIn account. That's usually how people find me. I always remind people it's AIMEE, Aimee with the two E's, to find me. But usually, that's a great place to reach me.
Excellent. So we'll link to both those links in the show notes at the Integrative Pain Science Institute, specifically to Aimee's LinkedIn page, where you can reach out to her and link in with her and ask her questions if you need to. I know many of you are interested in this topic of deprescribing in physical therapy, so make sure to share this with your friends and colleagues on whatever social media handle that you're active on. I'm oftentimes on LinkedIn, or Instagram, you can find me at Dr. Joe Tatta. It's been great being here with you this week, and we'll see you next week.